All right, let's dive into the prevention of ischemic stroke. Now, we're not talking about preventing a stroke from ever happening in the first place. No, we're focusing on something much more urgent. What you do after a patient has already had that warning shot, a transient ischemic attack, or TIA, or maybe a mild stroke. For these patients, believe me, the clock is already ticking and the stakes are incredibly high. And just how fast is that clock ticking? Well, for patients who are considered high risk, the chance of having a full-blown, disabling stroke within just 2 days of a TIA can be as high as 8%. That is a huge risk in a tiny window of time, and it really highlights why everything we're about to cover is so critical. This is not a wait-and-see situation. It's a true medical emergency that needs immediate and optimal management. So here's our game plan for today. We're going to build this up in 6 steps. First, we'll look at risk factors and what our goals of therapy are. Then we'll get into the detective work, the essential patient investigations. After that, we'll cover non-drug and surgical options before taking a deep dive into the 2 big drug classes, antiplatelets and anticoagulants. And finally, we'll wrap it all up by talking about special populations and some key pearls you'll want to remember. Okay, let's kick things off with Section 1, identifying who is most at risk and, really, what are we trying to achieve? The immediate goal here is pretty straightforward and absolutely vital: prevent a disabling stroke or, even worse, death. So, how do we actually spot these high-risk patients? Well, it boils down to a few key factors you see here. We're looking for patients who are over 60, those with high blood pressure, and anyone with a history of diabetes. Clinically, the big red flags are motor weakness, any speech impairment, or if their symptoms lasted longer than 10 minutes. If you see any one of these, that patient needs to be investigated and treated immediately. We're talking same day if possible. So what are we trying to accomplish? Well, there are really 2 main goals. The primary, immediate goal is obvious, right? We have to stop another stroke from happening. But we also have to play the long game, and that's our secondary goal: preventing death from any vascular cause. You see, a TII isn't just a brain problem. It's a massive warning sign for that patient's entire cardiovascular system. Okay, so we've set our goals. How do we investigate? This section is all about the clinical detective work we need to do to figure out the root cause of the TIA or stroke. This is so important because it's what's going to guide our entire treatment strategy from here on out. The investigation always starts with the fundamentals: a really thorough history and physical exam. For the history, you're digging into the specifics of the symptoms, of course, but you're also hunting for those key vascular risk factors. And listen, in younger patients, you have to cast a wider net. Think about things like trauma or coagulation disorders. The physical exam has to be complete, including a full neuro and vascular assessment. And critically, you've got to check blood pressure in both arms. From there, we move into the core diagnostic workflow, which really has 3 key steps. Step 1 is all about imaging. We need a CT scan right away to rule out a brain bleed, followed by a CT angiogram to get a good look at the vessels. Step 2 is labs, all the basics like a CBC, coagulation studies, and your metabolic panels. And Step 3 is all about the heart. A baseline ECG is an absolute must to check for atrial fibrillation. If you don't find it but you're still suspicious, you might even consider a 30-day loop recorder to catch those sneaky arrhythmias. Now, in some cases, especially with younger patients, the cause just isn't obvious. This is what we call a cryptogenic stroke. Basically, it means we can't find a clear reason why it happened. And when that's the case, we have to dig a little deeper. That could mean doing a transesophageal echo to look for a PFO, that's a patent foramen ovale, a small hole between the heart's chambers, or maybe an MRA for an even more detailed look at the arteries. All right, we've covered the workup. Let's shift gears and talk about treatment. We're going to start with the foundational therapies that pretty much every single patient needs: non-pharmacologic changes, and for a select group, surgical intervention. This algorithm here is a great visual overview of our whole strategy. See how it all starts with that TIA or mild stroke? Now notice the very first step is the same for every single patient. Control vascular risk factors. That's the bedrock of everything we do. It means getting aggressive with blood pressure, cholesterol, and diabetes, plus all those lifestyle changes: diet, exercise, and of course, smoking cessation. This part is completely non-negotiable. After that, you see the path splits depending on the cause. If it's atherothrombotic, caused by plaque in the arteries, we go down the antiplatelet route. If it's cardiogenic, coming from the heart, we're looking at anticoagulant. Now, for some patients with a major blockage in their carotid artery, surgery is an option. But, and this is a big but, the criteria are very specific. For patients who have symptoms from a stenosis of 70% or more, a carotid endarterectomy, or CEA, is recommended, and you want to do it fast, ideally within 2 weeks. The bar is set much higher for patients without symptoms. For them, you'd only even consider it for a very severe stenosis, and only in a patient with a good life expectancy. Even then, just managing them with medications is often a perfectly fine alternative. Okay, let's follow that first path on our algorithm, the one for atherosclerotic events. In this world, antiplatelet agents are the absolute cornerstone of therapy. Their job is to prevent strokes caused by plaque building up inside the arteries. We've got 3 main players on the field here. First, you've got ASA, or aspirin, which is kind of our baseline. Then there's clopidogrel, which offers a small but real benefit over ASA. And then you have the dipyridamole/ASA combo, which on paper shows the best relative risk reduction for stroke. But here's the critical trade-off. That combination is notorious for causing really bad headaches. And I'm not talking about a minor side effect. It's a huge reason people stop taking it, which, of course, completely defeats the purpose. So this leads to a really common question, something you definitely need to know. We use dual antiplatelet therapy, or DAPT, with ASA and clopidogrel all the time in other heart conditions. So does it make sense to use it for long-term secondary stroke prevention? And the answer is a very clear and emphatic no. This is a massive safety point. It might feel like more is better, but long-term DAPT in this situation just doesn't provide enough benefit to outweigh the significantly increased risk of major bleeding, including the one we fear the most, bleeding inside the brain. But, and this is the exception you absolutely have to remember, in the acute phase, right after the event, using DAPT for a short period, like 21 to 30 days, is beneficial. Understanding this nuance, no for the long term, yes for the short term, is just absolutely critical for safe and effective practice. All right, time to pivot. We're moving away from the arteries and focusing on the heart. We're now on that other branch of our algorithm, anticoagulants. Their main job is to prevent strokes that start in the heart, and the most common cause, by a long shot, is atrial fibrillation. The classic anticoagulant, of course, is warfarin. For most patients, we're aiming for a target INR of 2.5, and it's so important that they spend more than 70% of their time in that therapeutic range to be effective. Now, for some high-risk patients with AFib who've already had a stroke, some guidelines might even suggest pushing that target a little higher, up to an INR of 3. But these days, we have the modern alternatives to warfarin, the direct oral anticoagulants, or DWACs. And this table is packed with key details for pharmacists. I mean, look at the specific 2 of 3 criteria you need to dose-reduce apixaban, or the hard renal cutoff for dabigatran. It's contraindicated below a creatinine clearance of 30. And definitely pay close attention to those major interaction pathways, like P-glycoprotein and CYP3A4. These are the details that matter. Okay, in our final section, we're going to cover some really crucial management points for special populations, specifically pregnancy and breastfeeding, and then we'll wrap it all up with a few high-yield therapeutic tips you can take with you. Managing these patients during pregnancy and breastfeeding is all about making careful choices. For an antiplatelet, low-dose ASA is your go-to in both scenarios. For anticoagulation during pregnancy, we use low molecular weight heparin. Why? Because warfarin is teratogenic, and we just don't have enough safety data on the DOACs. But then things change for breastfeeding, where warfarin is actually considered a safe option, while the DOACs are still an unknown. And you'll notice in both situations, statins are generally avoided. Let's tackle a common historical misconception. For a long time, there was this idea that hormone therapy might actually be protective for postmenopausal women. So what does the evidence really say about its role in preventing strokes? The evidence on this is crystal clear. The risks totally outweigh any potential benefits. Hormone therapy is not protective against stroke. As a matter of fact, it does the opposite. It actively increases the risk of stroke by about 40%. That is a definitive, no-nonsense takeaway. And for our very last point, let's turn to younger women. Should hormonal contraceptives be used if a woman has a history of a stroke or a TIA? Well, the evidence is pretty clear. They really should be avoided, especially if she has other risk factors hanging around like hypertension, smoking, or migraine with aura. And this just reinforces the ultimate goal of everything we've talked about, finding the safest, most effective path forward for every single individual patient.